Good afternoon and welcome to our free Nursing Times webinar on why nurses must be supported to innovate. My name is Steve Ford and I'm the editor of Nursing Times. I'm delighted that you can join us for the event, which is delivered in partnership with Vocera, now part of Stryker. First of all, I hope you're all well and that you can see and hear us all right. Second, I'll quickly explain why we are here today. As everyone in the profession knows, nursing is facing a global staffing shortage unlike any we've seen before. One way we can support the workforce is by responding to the profession's call to innovate in the delivery of care. So today we're going to be discussing how we can best address nurses' call for innovation and improving the work environment. We'll be looking at themes such as why must health and care leaders support nurse innovation? Why does a difficult work environment look like for nurses? What does a difficult work environment look like for nurses? How can we target innovations at nursing's biggest challenges? And why are nurse leaders essential to support innovation? We are lucky to have our special guest speaker, who is Dr. Rhonda Collins, Chief Nursing Officer at Vocera Communications and author of the Reimagining Nursing for the Future report. Rhonda is a well-respected nurse leader and technology expert, a fellow of the American Academy of Nursing, and has met US presidents. So a massive welcome to Rhonda. In a minute, she'll be speaking to us about her new report. After that, we have a discussion to unpack the themes of nurse innovation in more detail, and then it will be over to you to ask any questions that you have or give views or both. So don't miss your chance to join in the conversation and engage with our keynote speaker, who is ready to engage with you and give her views on these important themes. So to get involved, please send us your questions whenever you think of them using the Q&A button in Teams, and I will put them to Dr. Collins on your behalf. So we've got around an hour, so without further ado, I'll hand over to Rhonda.
Thank you, Steve. Thank you so much. It's really a pleasure to be back with you and have this conversation. Next slide, Melissa. Nurse leaders are facing unprecedented staffing challenges, as Steve said, and with role vacancies leaving gaps in the care process, we have to find ways to use systems and technologies and improve processes to ensure quality patient care. So people frequently ask me, how do I come up with my topics, or how do I decide what to focus on? And really, I've made a practice over the years of listening to the voices of nurses, specifically nurse leaders, their desires, their concerns, their ideas. And the annual CNO Perspective Report reflects the voice of nursing leadership and details what we can do to improve this experience. Next slide. So obviously we need more nurses. I'm not going to spend a lot of time on this because I'm telling you what you already know. But 27% of staff said there are enough staff at their organization for them. That should read, there are not enough staff at their organization for them to do their job properly. 13 million is the number of nurses we need to fill global shortages in the next decade. The World Health Organization anticipates that that number will continue to grow if we have the continued attrition that we have right now. And 1 in 10 nursing posts estimated to be vacant across NHS England. So these are the numbers that you were facing. It's not news to anyone, and it's certainly not a controversial topic or subject, and you can go anywhere and find statistics that support the fact that we are in a situation where we cannot educate enough nurses to pull us out of this gap. And somehow we've got to find more efficient ways, or more intuitive ways, or more innovative ways to deliver care. Next slide. So what is the problem? What's the problem we solve as nurse leaders? Let's look at what we do know. We know that burnout is an issue. Nurses are taking care of more patients with fewer resources, and we risk them leaving the profession. We know that we aren't going to see significantly more nurses in the profession because we don't have the capacity to educate them in most places. So we have to retain the nurses that we have, and we have to ensure that their time is well spent and it's not wasted. So how do we do that? Next slide, Melissa. I love this slide. because it really addresses that we can change the environment. It's perhaps custom made for our situation right now. When a flower doesn't bloom, you fix the environment in which it grows, not the flower. I get very frustrated when we start blaming nurses for not being resilient enough, or the new word is grit, or they're not showing enough grit, or they're not coping well. We're blaming the individual for the situation that they find themselves in, when really it's the environment that has delivered the injury. We accept it as normal, and it is not. And so now is the time to address that and really move forward with looking at how do we change this environment. Nursing has held a long prevailing position that the hospital environment is set and it's defined. And no matter how inefficient it is, we must learn to work within it. And everyone listening who is a nurse knows and understands that frequently it's the nurse that absorbs the dysfunction. It's the nurse who finds the workaround. It's the nurse who has to, is the hub of the wheel, who takes information and data from every department in the hospital and puts it together in order to care for the patient. Patients are in the hospital for nursing care. That's why they're there. We must acknowledge, again, that the burnout nurses are experiencing is a work-related injury, and the environment is the mechanism that delivers that injury. Next slide. So I am a hiker. It is where I relieve my tension and stress. This photo was taken up in Red River, New Mexico, and it was at about 10,000 feet, hiking up to almost 12,000 feet to an alpine lake. So I will tell you, last October, I had a hiking incident on top of that mountain that earned me 3 days in the hospital. During those 3 days, I saw firsthand how difficult the environment can be for nurses and its impact on patient care. I talk about it all the time. I worked in the hospital for over 20 years. I was a nurse executive in one of the largest hospitals in the United States. I understand the process of what we do, but when you're a patient and you're in that bed, you have an entirely different view. As I sat there in my fishbowl room, invisible to the nursing staff behind a pulled privacy curtain, I had a lot of time to contemplate how disconnected most systems were in that patient room and in the hospital environment. The only way the nurses knew I had gotten out of bed was because I disconnected my own monitors. The only way they knew I had turned on my preferred left side to sleep, which the doctor had asked me not to do, but in my sleep I would turn on my left side, was if they came in and found me. The only way they knew my IV pump had a problem was if I told them, because they couldn't hear the alarms or beeps from my room. I observed how difficult it was for everyone to simply communicate. Each doctor wore multiple bleeps and carried personal cell phones. Each nurse carried a ward-based phone and a personal cell phone. Because the ward phones used randomly assigned numbers that changed every day, the nurses also had to carry a piece of paper with assigned 4-digit numbers for the day that changed every day that they showed up to work. Each nurse wore an earpiece that required them holding down a button so they could communicate with their immediate team of caregivers, including the nursing assistants or the LPNs. I asked one of my nurses the purpose of all the devices, and she explained that she used her personal phone to text or SMS the registrars and doctors. The ward-based phone was to connect with other nurses on the unit, and the earpiece was to talk to her immediate team. Not a single communication device was integrated with the electronic health record, medical devices, or essential groups like lab and pharmacy. This hospital was so short on nursing staff, and it was a teaching university hospital, but they were so short on staff that the doctors and registrars managed many nursing tasks for me and providing my care. The registrar who provided my discharge instructions actually said to me, "Go to a hospital 30 miles away if you need follow-up. The short staffing of nurses here will complicate your care." I was devastated by that message. And I thought, how can we change this environment? Next slide. How do we change this environment for nurses? How do we make it a sustainable environment? So here are some ideas and suggestions from talking to nurses and interviewing and observing firsthand from my position in a patient bed. Next slide. Listen, create the space your nurses need to thrive. Every nurse who came in my room obviously knew what I had done. I had actually worked for that health system in the past. And so I had quite a few people who knew my name. And so I would listen to them. I would say, what's your biggest challenge? What frustrates you the most during your shift? And they said, I just want my nurse leaders to really listen to me. I want the environment to be created where I'm not hesitant to speak up, where my opinion is validated and it is realized as one that is essential to the next steps of how we grow. Next slide. So last year, from July through October in 2021, I conducted a survey of more than 500 nurses from more than a dozen countries, asking them to recall a communication experience during their most recent shift. In describing their experience, only 17% of them said communication was efficient. Whether that was talking to the doctors and the extended care team, their supervisors, their head nurses, the patient and family, or to each other. 1 in 5 had challenges with communication processes taking too much time or taking too long. 16% had trouble just getting to the right person, and 11% indicated that resources were stretched so thin that impeded communication as well. Next slide. So here's what we have to do. Number 1, I have about 6 points here. Simplify and unify workflow communication. Nurses and doctors and other healthcare staff are just like everyone else. They want simplicity. We don't want our lives to be complicated. And I frequently point out that all of the tools that we use in our everyday lives to make our lives more simple, to make information flow more easily, are frequently absent from our work experience. We have to put away all of that technology. We can actually pay the babysitter off of our smartphone. We can schedule food to be delivered to our home off of our phone. We can have quick conversations with family members to say who's picking up the children from daycare after school and all of those things, but yet we have to put away all of that convenience and go into our workspace where we're still using bleeps, we're still using sometimes fax machines, we're still using antiquated technology that is not integrated. So why should work require all of these healthcare professionals to use a bleep, a personal phone, or a hospital provided device? Why should they have to look up numbers and determine who's filling a certain role that day? Shouldn't they be able to just say, call the respiratory therapist on call? And the technology would assist them for that. I give a perfect example. I have 2 grown children. I don't know their phone numbers. If you ask me now to recite their phone numbers, I couldn't do that for you because my technology carries the burden of memory for me. And it allows me to just say, call Justin, my son, and it will call him. So I submit that one of the greatest things that we can do is simplify that environment. Look around and say, what could be easier? What is already easier and is available for us to use? The technology exists today to make communication fluid across all platforms, across all individuals. All we have to do is access it and use it. The security that we need to employ is available. All of these things are readily available for us. Next slide. In my work with nurse leaders to seek out innovative ways to reduce workflow burden and create new models of care, I always begin by looking at the work environment to identify opportunities for streamlining the nurse's workflow. We have an outstanding clinical executive who works in the UK who does the same thing, who observes workflow, who understands exactly how nurses work, and David can go in and identify immediately where inefficiencies lie. And it starts with improving communication, and communication, I will say, is the foundation of everything that happens in a hospital. You think about how many hundreds, sometimes thousands of times a day, the nurse has to process information on just one patient. And then you multiply that by however many patients they have for the day, and you're looking at thousands and thousands of bits of data and information and communication that they have to assimilate. So I say a single unified platform is essential. You give the choice to the individual if they want to use a phone, if they want to use a hands-free wearable, if they want a combination of above. All of those things enable communication without disrupting patient care workflow, and nurses and physicians should be able to reach the right person by role or number or without carrying a name or a list of numbers. Next slide. So let's talk about connecting mobile care teams. In response to staffing pressures, many hospitals are turning away from primary nursing and moving to team nursing, as we refer to it. In the US, you may have a different designation for it, but basically one RN, a registered nurse, will manage a team of caregivers that include patient care assistants, LPNs, and other certified assistants. So this team will take care of a larger number of patients rather than just primary nursing, which is one RN to 1 to 6 patients or so. Communication is a fundamental bedrock of building trust and creating a team dynamic. For such a team to function effectively and for one person to guide an entire team to take care of multiple complex patients, effective communication and workflows are imperative. Mobility is also essential. That's the point I want to make on this. A stationary nurse can't manage a mobile team. It's impossible. Everyone has to be mobile. Care teams can only be mobile when they are mobile, when they can take their tools with them and information can move with them. Requiring them to move tools and information hinders workflow. They must be able to access it from wherever they are. Next slide. Integrating communication with a hospital's ecosystem of people and clinical systems so actionable information can be pushed to the right person at the right time and place. And nurses rely on actionable information throughout every shift to make decisions in the moment and manage patients to achieve good outcomes. And you can see what we do with Vocera is we use a middleware to take information from the EHR, nurse call, patient monitoring medical device, any number of medical devices, beds, all of the devices that can send information can go through the middleware, and then the needed actionable information can go to this team who is caring for multiple patients as evidenced on the bottom right of the screen. Next slide. And I think this next slide is probably the most important point I want to make, is that we have to transform hospital systems into nurse extenders. A nurse extender is a technology, tool, or process or protocol that extends a nurse's reach and influence. To think of how to transform the hospital systems into nurse extenders, you have to start with the patient. Next slide. So where do you find the patient? In the bed. Many hospitals use smart connected beds that can be integrated with a communication system. A smart bed can almost immediately notify the correct caretaker when a patient is in a compromised state and at risk for injury, specifically helping to reduce falls and decubitus ulcers. For example, a nurse can be remotely alerted if a high-risk patient is attempting to exit the bed, if a bed configuration is not in compliance with hospital protocols, and if a patient has not been turned in a set time frame. Information can be sent from the bed to the mobile nurse's communication device of choice, whether it's a phone or a wearable. Receiving real-time actionable information enables the nurse to actively manage the patient even when outside the room. So one of the things I noticed when I was a patient in the hospital was literally nothing was connected. Everything was disparate, everything. And I felt like I wanted to help the nurses by connecting the information for them. That was one of my goals, was to try to connect that information for them. Next slide. Innovate care models. This is one of the most important things we can do. Two of the most time-consuming tasks a nurse has are the admission assessment and discharge teaching. So I would say consider enabling virtual nurses to assist with admissions and discharges over video. One hospital I've worked with has saved up to 29 minutes per discharge for the bedside nurse by having virtual nurses engage with patients and provide teaching on discharge instructions via webcam. They simply communicate seamlessly with each other to say, this patient is ready for discharge. They roll in the webcam, and then that nurse can take care of all of the questions. It's especially satisfying for hearing impaired nurses because they're talking to a nurse live over webcam who does not have a mask on. They're able to read lips, they're able to see. Their patient satisfaction really went up through this experience, that they were able to use the innovative way of just allowing nurses to rotate through this discharge and admission process. Obviously, part of the admission process requires the physical assessment, but there are many, many questions that have to happen that the virtual nurse can care for. If a nurse has 4 to 6 patients and can save 29 minutes per patient for discharge and 15 to 20 minutes for admission, you're looking at giving back every nurse almost an hour of their time. And if you have 6 or 7 patients, that's 6 to 7 hours in a shift. You look at every minute because minute is a metric that counts. Having a virtual nurse live on video can really make a difference for patients feeling very engaged in how their hospital experience is going. Next slide. So let's talk about a couple of things that are really top of mind, I will say, in most of the conversations that I'm having. If a nurse is overwhelmed or stressed, we have to ask questions. If there's not more nurses, we can't hire more, then what can I do to make your workload better? What can I do to make this workload one that you can manage and doesn't overwhelm you throughout the day? So I'm hearing some amazing ideas from bedside nurses who want to contribute to solving the enormous staffing problem, but they feel that they need options. They need another way to work. One of the top priorities I'm hearing about is gig nursing. So when I talk about gig nursing, I would say think of Uber. You know, Uber is really an answer to the gig economy, where people are working jobs as needed and filling a need wherever it is. The gig economy is coming to nursing. I absolutely am convinced. Imagine you need a wound care nurse for a few hours to round and teach, but you don't have that expertise in the house at the moment. You don't have that person in hospital at the moment. So you could use an app to place a request. Wound care nurses who are on your registrar of nurses who are certified to work in your hospitals are able to provide the expertise. So you put the request out on an app, they see the app and they say, I'll go in and do wound care for 4 hours or 6 hours, and I will teach the nurses who are trying to learn it because I have years of expertise. And they answer the call to be efficient that way. Sometimes we use IV start nurses who are really have an expertise for difficult IV starts in geriatric patients, and you could put out a call for an IV start nurse to come in and work a while. You could put out a call for a nurse to come in and relieve for lunches or breaks who could come in. These are nurses who've made the decision that I don't have it within me at this moment to sustain an 8, 10, or 12-hour shift, but I do have it within me to share my expertise and to support my profession, and I want to be part of that. I would say you think of it as the pro Renata or the PRN for the 21st century. Allowing nurses to define their shift, to define their work, and using them where you need them. The next one I would say is respite rotations. Many hospitals are creating hospital at home care models where nurses can rotate out and have the experience of caring for patients outside the acute care environment. The virtual nurse teaching discharge and admissions is a rotation that some hospitals use to allow nurses to have that moment to just get away from the intensity of the environment every day in the wards and to be able to go ahead and work in a different role, in a different way that allows them a moment to collect themselves. Mentoring. Many nurses entering the workforce today have never touched a patient due to COVID-19 restrictions limiting their access to hospitals. Excuse me. Meanwhile, experienced nurses who can no longer work a long shift are retiring, taking their wealth of knowledge and expertise with them. So consider hiring retired nurses or nurses who can no longer want to or who can carry a patient load, but have this wealth of knowledge, this brain trust of how to care for complex patients who can come alongside the younger nurses and just teach and mentor and allow them to have that experience of, I would say, knowledge transfer to help them grow and create that confidence that they need to become the experienced qualified nurse. When we look at statistics in the United States, the highest number of nurses leaving the profession are nurses with less than 1 year of experience. The reason for that is that overwhelming sense of not being knowledgeable enough to care for patients and the stress that goes with that. Many of them said, if I just had an experienced nurse who could walk along beside me, who I'll do the patient care, but they can tell me what to look for, what something looks like, what a certain symptom is, and allow retired nurses to have 2 or 3 hours in the hospital, you know, to really do that knowledge transfer. Next slide. And identify tasks to offload from the nurse. Next slide. My mother was diagnosed with diabetes decades ago. She's performed her own finger sticks for literally 40 years. Yet when she's admitted to the hospital, that task is taken away from her and it's given to someone on the nursing team. And she frequently complains to me, I can do this better. I know where it hurts and where it doesn't. I wish they would just let me do my own finger sticks. Nurses should not have to spend their valuable time doing these things. Give patients a smartphone app, a bedside tablet, or even pencil and paper in the room to document their own intake and output, their blood sugar, their ambulation in the room. Of course, the patient must have the cognitive capabilities to perform these functions, but the idea is to evaluate every single task and determine if only the nursing team is qualified to do it. For example, is a license required to turn, ambulate, or bathe the patient? Teams of highly trained and individuals can provide integrated quality care when you're communicating effectively and easily. Next slide. Empower nurses to manage the patient and family experience. I mean, this was really a problem during COVID. Next slide. We really had to keep families separated, so keeping them informed turned into quite a time-consuming task. We were really working to create ways we could keep the family informed. And when they're separated from the family, patients are separated from the family, it causes stress and anxiety that needs to be alleviated. I have seen apps, to be able to use apps that empower the nurse to control the information, to alert the family that we are sending out information on this patient at this time, to have live video conversations with the patient. All of these things require, you know, security that allows you to have that secure information that transfers information about the patient's condition. But it's an investment in smoothing communication that pays huge dividends in specific task-related work that eliminates the phone calls and the constant repeated phone calls, wanting to know about a loved one, which they have every right to know about their loved one, but it can become a time-consuming task to manage that flow of information. So when you give the power back to the nurse is able to manage it. Next slide. Nurses are innovators. We just need to listen. It may seem like a very small idea, but that small idea can turn into something that saves minutes, and minutes can turn into hours, and hours can turn into half a shift. Those are the things that we have to look at. And so when you start to evaluate and you can compress these tasks, you can offload tasks, or you look at ways to extend the reach of the nurse. That is the one thing that I think is the most important thing. We're bringing in the electronic health record. All of these things are designed to extend the reach of information. So how do we extend the reach of the nurse? As nurse leaders listen and respond to their nurses' appeal to change the work environment and innovate care models, you as a nurse executive or a nurse leader have an essential role in finding ways to use systems and technologies or improved processes to ensure quality patient care. Communication technology integrated with systems and devices can fill the gap when staffing is a challenge. Yet, whether it's streamlining workflows, improving communication, are identifying tasks to offload from the nurse. The only thing that makes technology useful is defining the workflow and the problem that it's solving. Technology for the sake of technology is not a solution. For technology to bridge the gap and enable people or processes, the nurse leader must provide the intelligence to enable it. It requires nurses to sit at the table, to work with our information systems, to define the actual workflow. Information systems can tell you how the technology works. Nurses can tell you where it needs to work and how it needs to work. We have to be able to pull together the expertise of everyone who really understands the environment to change it. You are the ones who understand nursing workflow, and you must be at the table when decisions about technology for communication and collaboration are being made. Question assumptions and conventions and make sweeping changes one workflow at a time, and ensure quality patient care by supporting and equipping the nurses who deliver it. Thank you for your time. I'm open for questions and I look forward to the conversation. I'll share some conversations that we're having here since Steve has gone offline with all the questions. But some folks were asking if this can be used in the community. The technology can be used on calling into the hospital on the cell phone, because frequently what we try to do is connect the community health or the hospital at home with the doctors in the hospital. So yes to that. Another question I'm frequently asked is, how can we integrate with the electronic health record? And the answer to that is yes. To send information from your EHR, you can certainly do that as well and send it to a mobile device. I don't believe I would ever replace a workstation with a phone. I think that creates a kind of workflow problem for the nurses, but certainly to enable or to facilitate information using a phone. If anyone has a question, you can certainly put it in chat.
Hey Rhonda, we've had one come from the chat, which is any tips to identify tasks which could be offloaded?
Yes, I think the first thing you have to do is go through a nurse's workflow for the day, look at everything that they do, from finger sticks to blood pressure checks to ambulation to documentation, everything that you do, and look at it and say, does this actually require a licensed nurse or caregiver to do this? Does this require a nurse? Or and then the next step after you've done that is to look at, okay, what do we have over here that can be offloaded from the nurse? Now, what can we give to the patient and the family to help them become more invested in their care, to help them to manage, or perhaps just because they prefer to do it, like my mother prefers to do her own finger sticks. So those are the things. I think you take the everyday look, and then you say, really, I don't need to do this. And sometimes you have to challenge your own convention of thinking, because the tendency is to say, okay, I've always done this. I feel like this needs to retain with the nurse, but actually the activity of doing it doesn't have to stay with the nurse. It's just the communication that the task has been completed has to go to the nurse. And that goes back to that communication is the foundation of everything that we do. To ensure that the communication flows appropriately and folks are not repeating tasks or something can fall through the crack.
Brilliant, thank you. And then we've had another question, which is, can you expand on the gig nursing, please?
Yes. I was a judge for the nurse hackathon that happens every year. And one of the innovations that, in fact, it was the innovation that won the hackathon in my division, was looking at creating an app, or hospitals creating a registrar of nurses who have met all of their requirements to work in their field or work in their hospital, who have a specialty. Many nurses are leaving the profession and they'll say, I just want to do this task that I do, whatever that is, or that one expertise. I'm a midwife, or I enjoy doing and teaching about wound care. And so that's the specialty. And that day when you show up to the hospital, and at hospital you need that expertise, then you can put out the need, just like calling for a ride on Uber. And nurses can respond to that and say, oh, I'll go in and I'll work 6 hours and do this because this is my expertise and this is what I like. Or they can say, I can't do that today. My children need me, or whatever. And I think that that's what we're seeing is nurses are saying, I want control of my schedule. I want to use my expertise. So how do we facilitate that through, basically that is the very philosophy of the gig economy is, I will do this for this amount of time and I get paid for that. And then I'm able to manage my own schedule and my own work life, etc.
Hi, I'm back. Thank you very much, Rhonda. I'm not quite sure what happened there. Gremlin, of course. But, thank you very much. So yeah, thank you very much, Rhonda, for your brilliant presentation there. I suspect everyone will be nodding in agreement with so much of what you've said, especially on what you were talking about around the makeup of teams and on losing newly registered nurses so early in their career. I thought more positively, virtual nurses sounds very interesting, especially the impressive time saving on that. And as just discussed, gig nursing caught my attention as well. So thank you very much for sharing your personal experiences too, which I think will resonate. Interesting hearing about the phones and all the phones, sorry, and even having all this technology, it's just not linked up and communicating with each other. Again, I just think that will chime with everyone's experience, really. Yes, obviously we've started the Q&A, so thank you for colleagues for picking up the baton there. I've got a couple of questions as well, but also we've got a few more coming in, which is great to see, so keep them coming. So Cheryl asks, do you feel technology integration is easier in a corporate run healthcare system? So I guess that means as opposed to a public sector system like NHS.
Yes, you know what, I don't feel that it's easier. I feel that sometimes there might be more resources across a larger entity because it's, sometimes corporations can span countries and continents, etc. What I will say is that for there to be a good technology experience, it has to be a commitment and a priority of the organization. And it requires more than one or two people at the table. It requires the multidisciplinary approach and the prioritization of funding for that to ensure that integration happens. I mean, technology for the sake of technology doesn't usually solve problems. When it's addressing a very specific need and it's integrated with the systems and process in the hospital is when it really can make a difference.
Yeah, again, that was a phrase you used in your presentation that charmed me as well around technology, not for its sake. Great, thank you. Thank you, Cheryl, for that. A question in from Yvonne. So again, this has obviously really got people's attention, the gig nursing again. So have you any experience of gig nurses working in acute care? Yvonne points out we've got agency nurses, but clinical nurse specialists wouldn't normally work to fill a gap for a couple of hours, but it's a great idea, she thinks, and asks what's a good starting point. So I guess where would you start with gig nursing?
Gig nursing, I would look for areas that I mean probably the lowest hanging fruit, as we like to say. The first area you can start is just allowing nurses to have a break. I mean, frequently, we hear about nurses who don't have adequate time for food and water and breaks to relieve themselves and all those things, and start looking at environments that are always hyper congested or hyper busy, and look for ways where you can put out a call for a gig nurse who says, I'll come in and work 4 hours from 11A to 2P, to allow people to have a break and have a bowl of soup or a sandwich, or I'll care for patients and allow them to have this moment to collect themselves. I mean, that's the first thing you can look at. And then you can start looking at actual tasks, you know, where you need an expertise, where it's not always in the hospital for this expertise. But yet on this particular day, you have a patient population who needs that expertise, and start identifying what that is, you know, because all hospitals are different with their patient population, you know, what is a priority, et cetera, and start looking at how do I leverage this expertise that we know is out there, because they're no longer working full time, but they would work a few hours here and there. Those are the things that you have to look at. And just really, I think the challenge to creating the gig role is letting go of our assumptions of what it looks like to staff, you know, what it looks like to have expertise. Really break down why you believe that, and then start looking at how do we bring nurses in to fill that need, and then how do we use technology, whether it's an investment in technology or something that we already have that we can add on to extend the reach of the nurses and allow that information. Or because fundamentally how you care for patients is it doesn't require a nurse to turn or walk or, you know, ambulate or any of that, but it's the information that goes to the nurse who is the head of that care team, who has to make the informed decision and direct that team and guide that team. And so that's what we need to look at, is how do we extend the nurse's reach through moving that information back and forth.
That's great. Thanks. Thanks. Great question there, Yvonne. So I just wanted to sort of just return really to innovation as a sort of a broader theme, if I may. I suppose this is quite an open question, but do you think we're doing enough to support nurses innovate sort of globally?
I don't, and I think that that's why we're having such a conversation about it. I think that I participated in many like Twitter discussions about how to do this, and conversations across the world and other countries about what is frustrating nurses in the current work environment. And what they're saying is, you know, we want something more. We don't need more money or time spent on wellness breaks or how to be more resilient. Or one nurse said, my hospital gave me a resilient kit. And a resilience kit, she says it was sort of like a message of, you know, here's a book and, you know, something to take a hot bath with. Now get yourself together and be back at 7. And so she said that was not the answer. You know, what we want are sustainable solutions that make our work easier. And so that is, sometimes we think of innovation as being millions of dollars and huge investments, but it's innovation of thinking. It's innovation of process, and process then drives us to innovation of technologies. I wouldn't, you know, I don't say we always jump in at the deep end with technology. We have to identify the problem, and then how do we innovate this problem? And nurses will tell you if you ask them. You can just say, what makes it really hard to do your job every day doing this? And they will tell you. And then you can break down each individual act in the workflow and determine, can technology carry that burden of memory? Can technology facilitate that communication? Or can technology push that information? Where does that information need to reside? And then make it where the nurse is in control of it instead of, you know, the nurse having to chase it. They're in control of it. And that's really, I think sometimes we just think that we need a big bang, and that's not always the case. That we just need to look at how we're doing it, and let's innovate the way we're doing it, because sometimes it really is just a process change.
Absolutely. I suppose looking at it from slightly the other side, I mean, did you think nurses themselves generally feel like innovators? Are we getting the language right about encouraging nursing as a profession to take their ideas and change things?
I think in general, nurses are seeing if they don't innovate that the environment is not going to get better, and everybody wants it to be better. I do think that there is a certain degree of just people, whether they're nurses, who like things to remain to be what they expect when they show up. And I think that can be a huge challenge when we start changing things and looking at things. But I mean, there's myriad ways to bring people on board, to create teams, to really go through the process of change management. And I think that anything you do with technology or innovation or just looking at process has to be done through the lens of change management, because we're fundamentally changing how people view their profession, how they view taking care of patients. And many times it requires educating the patient and family to be a part of the new process and understanding that.
Absolutely. Again, I think we'll chime with so many people. I suppose just from a purely very practical point of view, do you have any particular advice for say a nurse who's watching, listening right now? You know, a light bulb's gone off listening to you speak, and suddenly thought, well, I've had this idea for ages on improving practice or efficiency, whatever it might be, or well-being. How would you advise them to make that happen?
I think I always say that, you know, be bold, be brave, and step out. Be brief, be bright, be brilliant, you know, and have that conversation with your nurse leaders and be willing to explain exactly why you feel that this is a change. And I'll just say, Steve, you should really create something in Nursing Times so nurses can send their ideas in on innovation.
Oh, we have that with an innovations hub, so yeah, absolutely, yeah.
Yeah, because, you know, nurses are really brilliant at, I always say we're brilliant at workarounds. You know, it's like, well, I have this and this, and I have to get over there. So how am I going to do it? And we create sometimes not very, I would say, functional workarounds, but it's the only thing we can do to get where we need to be. So I do think that nurses are extreme innovators in their thinking, because we cannot control what is happening in our workday. We cannot control how information comes to us. We cannot control how patients present, or, you know, how we start our day. The things that we can control, like treatments and medications and our response to things, is definitely causes us to innovate on the fly, because we have to respond to what the patient's symptoms or signs are telling us. So anyway, that is, I think that nurses are already thinking that. They just don't realize that they're thinking in an innovative way, because they're already having to consider, how do I care for this patient when I only have X and I need Y and Z, and this patient's symptoms are changing, and who do I notify? That's innovating in the moment. So take that, what drives you, and look at, how do I simplify my environment? And the only way that happens is for nurse leaders to really advocate for that. It has to be part of the dialogue. It has to be part of the culture, and it has to be part of what we use to motivate nurses as far as their professional growth. You know, how do you look at innovation, and how do you contribute to that in your work environment?
There you go. Perfect segue. That was my follow-up question, was why are nurse leaders essential to support innovation? So yeah, nailed it. Okay. So we've had another question in from Claire this time. So Claire says, excellent presentation, Rhonda. I wonder if there is space for virtual interdisciplinary team advice as part of discharge planning. Your thoughts on more interdisciplinary use of technologies and for stronger cohesive team working, perhaps? So that's quite a granular question. So around discharge planning and interdisciplinary use of technologies. Yeah,
you know, nurses who do discharge planning know that it can become quite intensive if you've got a patient with a newly diagnosed chronic condition or a disease like cancer. And so they have very specific steps that they need, very specific instructions that they need, and sometimes it can be very time consuming. So when you're able to have a virtual nurse who can spend all of the time, because they don't have another patient in that moment, they don't have a call bell going off, they don't have someone calling them, but they can be on a screen, like I am speaking to all of you, having this conversation so that patient really feels like they have the undivided attention. The one hospital where we worked on looking at metrics, distinctly in the discharge process, what happened was the nurse caring for the patient would use the Vocera technology to notify the discharge nurse that they had a patient ready for discharge. And then the discharge nurse, who was virtual, was able to work that in and say, I will be with this patient in 30 minutes or 45 minutes whenever we're ready for this. Then they would be able to facilitate the conversation right in the room. They were able to do it through their hospital intranet, so it was on the tele screen. And then they were able to just have this conversation with the patient and ensure that the patient understood how to give their insulin with their newly diagnosed diabetes, or how to keep up their medication regimen, or all of those things that they needed to do. And so they found that the patients loved it, the family was more informed, and the nursing staff loved it because they weren't constantly being interrupted while they were trying to have this difficult conversation with the patient. It was the same with the admission. They didn't save as much time on the admission. They saved as much as 15 to 20 minutes. But as you know, our admission process can be quite lengthy. There's a physical process and then there's a psychosocial process. So they were handing off the psychosocial portion of that to the virtual nurse to really have that intimate conversation and then share that information.
Great, thank you very much. And now, question from Kerry, again, gig nursing. So she says, I love the idea of gig nursing. My concern is what happens if the task requested or the expertise required is not allocated. So do those doing gig nursing feel pressured to stay or feel guilty for leaving? So in the acute setting, this could be a factor, Kerry suggests. So I guess it's they turn up, do their hours, but everyone's short-staffed, and then what happens?
Yeah, I always say this is the burden that nurses bear. It's like, how can I make your pain go away? Do you need me to stay longer? Do you need me to, we're a very caring, giving profession. But I think that over the last 2.5, 3 years that nurses have learned, I have to protect myself. I have to protect my well-being. And so I'm here to perform a task and I'm here to assist you. And when I have finished this task, if you need more of this kind of task, I will do that, but otherwise I will hand off to move on. And there is a certain understanding among all of the staff. Let me get you this, let me do this teaching, let me mentor these younger nurses, let's have this conversation, but this is the hour at which I leave. And so I will say the whole idea of gig nursing is new, but it is really taking hold. And I think that nurses are energized by the idea that they can have some control over their work environment and still stay in their profession without just wholesale leaving. That's what we target with this sort of idea, is the nurses who are leaving anyway, because they can't sustain these long shifts and the emotional toll and the physical toll, but they have this great wealth, this brain trust that is exiting our profession, who wants to work in a smaller way, in a more focused way, and can say, okay, I can give my day or these hours to that. That's what we target with the idea of the gig nurse.
Perfect, thank you very much. As I said, the idea of gig nursing obviously hitting a spot with people. So I'm afraid to say we're just about out of time. So thank you very much to everyone who submitted a question, and sorry if we didn't get around to yours. You've been a superbly engaged audience, as you can see, of all the questions that we've been able to ask. So thank you very much to Dr. Rhonda Collins for her time, and again to Vocera Communications and Stryker for sponsoring this webinar. But before I let you go, Rhonda, I just wanted to finish by asking you if you had a key message that you wanted listeners to take away from today's webinar.
Yeah, thank you, Steve. Listen, know that there are solutions for all of your challenges out there. Sit at the table, have a conversation, determine how you can innovate to extend the reach of your nurse's expertise. I think that's the biggest message. And thank you again, Nursing Times and Steve, for this time. We really appreciate it. I've enjoyed it.
Pleasure. So on that note, thanks again to everyone for taking part. I hope you enjoyed it as well. Just to say, we've recorded the event, so you will be able to watch it back when you like at your leisure. So basically, thank you very much to everyone, and goodbye. Enjoy the rest of your day. Thank you.